Good morning. Today, I'll talk about Samrakshan, which is a national program of the Indian Radiological and Imaging Association that aims at reducing perinatal mortality in India. And we will look specifically at the research opportunities that exist for radiologists interested in fetal imaging as part of Samrakshan and the need for national data from India. As I mentioned, Samrakshan is a national program of IRIA that's aimed at reducing perinatal mortality in India through an approach that integrates fetal imaging studies with childbirth planning and is focused on conditions that are common to India, especially preeclampsia and fetal growth restriction. Samrakshan was conceived by Dr. Rijo Mathew and rolled out nationwide in India by the IRIA in 2019, and it's an ongoing program. Now, before we get into the specifics of research in Samrakshan, I would like to briefly talk about three myths or dispel three myths about research. One is that we need to be aware that research is a continuous searching and researching for the truth. So it doesn't stop at one single point. It's a dynamic process. So once you find what you consider as the truth, it has to be reevaluated and researched again to see if that is really the truth. And that's where dissemination of the research findings through different media become important. Research is also the balance of the normal and the abnormal. More often than not, we see people thinking and believing that research is only the study of the abnormal. It's not so. Research is a study of the normal and the abnormal. And the reason for that is, unless we are sure what the normal is, unless we can understand the normal, there is no way for us to say what is abnormal, or there's no way for us to know what's abnormal. The abnormal is based on our understanding of the normal. And the results of research have to be interpreted based on local context, based on local population characteristics, based on local population environment. So the interpretation has to be local. Even if it is a study done elsewhere, its interpretation has to be adapted and based on the local population characteristics where it's going to be applied. Let's look specifically at India, and within India, you can see an opportunity, and you can also see a need for studies. So there are about 30 million childbirths each year in India, and this is a big opportunity, 30 million childbirths each year in India, which gives us approximately 30 million fetuses or babies that can be studied through the course of pregnancy. More than 80% of these childbirths occur in institutions now, and hence documentation about childbirth outcomes, documentation about the process and progress during pregnancy is supposed to be available and of good quality. A debatable point, but that's something that we need to improve upon, and that's something that has to be considered carefully. But the documentation possibilities exist. Around 3.5 million premature births occur in India each year, which is a large number, 3.5 million premature births each year. About 35 to 45% of the fetuses are growth restricted, which translates to about 10 to 14 million growth restricted fetuses that are born in India each year. About 8 to 10% pregnant women develop pregnancy-induced hypertension, which translates to 3 million pregnant women with pregnancy-induced hypertension in India each year. And we have a burden of congenital malformations, 1.9% to 2.72%, which translates to about 6 lakh congenital malformations, fetal congenital malformations in fetuses born each year. So if you look at this, you can see that we have a large number of normal childbirths. We have a large number of normal fetuses. We have a large number of abnormal fetuses as well, or fetuses that pass through an abnormal course during the pregnancy. And there's no reason why we cannot study or compare the normal with the abnormal in our population, in our context, in our settings. We have large numbers to do that. And we must be doing that. So that is the opportunity, and there is a need for Indian studies. Needs that look at parameters that apply to our population as well. Specific to Samrakshan, when we work through the conception of Samrakshan, we decided that we have to look at conditions that are specific to India. Now, the Caucasian populations have got a good grip on preeclampsia, have got a good control on growth restriction. For them, the primary interest is going to be fetal congenital malformations, because these conditions are well addressed, reasonably well addressed. And the priority is congenital malformation. So for them, the research is going to be primarily on congenital malformations, fetal abnormalities. For us, as we have seen earlier in the numbers, preeclampsia and fetal growth restriction are the larger numbers. 10 to 14 million growth restricted fetuses, 3 million women with pregnancy-induced hypertension, and approximately 6 lakhs per year, 6,21,000 per year of fetuses with congenital abnormalities. So for us, the priority is different, has to be different, must be different. It must be preeclampsia and fetal growth restriction. However, in practice, what happens is that our entire focus is on, almost entirely on, identifying specific abnormalities in the fetus. And that's what we wanted to change through Samrakshan. We bring a greater focus on India-specific conditions. We also realized that we need India-specific data that are specific to India. And if you look at fetal growth and fetal growth parameters and estimated fetal weight, we find that we don't have a normative parameter for these to base our observations on in the ultrasound machines where these measurements are being carried out within India. We don't have a normative parameter for Indian fetuses. We have parameters based on Caucasian populations, other Asian populations, but not from Indian population. Now, considering that we have 30 million childbirths, the lack of that normative parameters is strange and something that must be addressed. And we thought we should address that through some direction. Basing our growth parameters and estimated fetal weight parameters on fetal parameters that come from Caucasian populations, we know it's very different. So estimations are going to differ. And it's imperative, essential that we have normative data from India. We also want trimester specific data. So we're shifting the paradigm of pregnancy from a third trimester focus to starting from conception through delivery. That includes a first trimester, that includes a second trimester, that includes a third trimester. We have great focus at each level. And a first trimester focus is equally important. It's not just estimating the EDD or the confirmation of pregnancy. It's also a place where you can start looking at the fetus in greater detail, assess risk for the mother, assess risk for future growth restriction, preeclampsia, and initiate interventions early for a better optimal result. So each trimester is important, and we want a trimester specific data. And we want all of this to be aligned with childbirth outcomes. Now, from a radiology perspective, much of the work is done on imaging, and then the report is handed over to the obstetrician, who then goes ahead with the decision-making on childbirth. And we want to strengthen the link between the fetal radiologist and the obstetrician who is doing the childbirth to make sure that the findings and the outcomes are aligned, they are looked at, and any corrections that need to be made can be made. In terms of possibilities, Samrakshan offers the possibility for the development of normative fetal parameters from India, whether it's fetal doppler parameters, whether it is structural parameters, growth parameters, environmental parameters, It gives the opportunity for us to develop normative fetal parameters from different regions of India, from different states of India, and then collate it to a national level also. And this is important because India is a big country with a diverse population, diversity in regions, and hence the growth parameters are going to differ from region to region. And we have seen that from few studies where the growth of fetuses, the birth weight and biometric parameters of fetuses from Vellore are different from those in Pune, which is different from those in North India. So these differences exist and it's essential, and Samrakshan offers a possibility to develop normative fetal parameters. Samrakshan is also focusing on the development of pragmatic testing guidelines that can be applied widely and at different levels, primary, secondary, tertiary care levels, diagnostic and prognostic effectiveness. And it aims to collect data and to use that data to drive India-specific guidelines for fetal radiology and imaging studies. So it's going to be a data-driven, where the levels of evidence are considered, the data, strength of the data is considered, the evidence is considered, and then the recommendations are made as to what can be done at which level. And then evaluate that to see if those need to be refined, evaluate those continuously and consistent. And then to develop a national registry for fetal abnormalities and fetal conditions with respect to India and its problem, which can inform policy, which can inform practice. Other possibilities include the ability to develop niche areas. Now, clinical radiology. Radiology is a discipline of medicine that is sort of confining itself to a large extent to images and reporting of images. It needs to rediscover its mojo. It needs to rediscover its strength as a clinical discipline. It's a clinical radiology, where you talk with the patients, you interact with the patients, you are getting the images of the patients, and you are providing recommendations to the patients, interpretation and recommendations to the patients. And from Samrakshan, we can look at the magnitude of fetal conditions. We can look at the magnitude of maternal conditions that affect fetal growth. We can look at risk factors. We can look at therapeutic interventions. We can look at outcomes, algorithms, the development of scores that are relevant to our population. We can look at developing normative data, diagnostic, prognostic effect, and all of this are part of clinical radiology. It's not just the identification of a structural abnormality in the fetus. All of these form part of clinical radiology, and Samrakshan aims to emphasize, re-emphasize upon these aspects of radiology. Implementation research is another area that Samrakshan is evolving into, and that includes understanding the strategies that are necessary to increase the uptake of radiology services in India in different populations. The National Family Health Survey 4 reported that around approximately 60% of pregnant women, only 60% of pregnant women had at least one antenatal scan during pregnancy, which means that 40% of pregnant women did not have an imaging study of their fetus during pregnancy in India. That must have increased now. The NHFS 4 was done in 2015-16, so it must have increased now. However, it's still suboptimal, and we are looking at strategies to increase the uptake of fetal imaging services. As we are doing that, we also have to look at the impact of this increased uptake, whether it's improved outcomes, has it improved childbirth outcomes, what has it improved? Has it improved early identification? Has it improved early interventions? And the barriers to take up these services. We're also looking at the health economics aspect of this, of screening using imaging. What's the cost effectiveness? What's the cost benefits? What are the cost utilities associated with screening programs using imaging? How does it compare with the cost effectiveness if we use biochemical tests, which are costlier, which are not easily available, affordable, or accessible for most people? So how does the cost effectiveness play out? Is fetal imaging using ultrasound and doppler a more cost-effective method for the pickup of pregnant women and fetuses with abnormalities? And Samrakshan aims to evolve further into considering the impact on the pregnant woman in terms of the quality of life, in terms of mental health outcomes like anxiety, depression, stress. What does it mean when an imaging study shows that a fetus is abnormal or is growth retarded, or we find out that the pregnant woman is at risk for preterm preeclampsia or has some other abnormality that's being picked up by the imaging study. How does that translate to an impact on the mother, father, and the family of that particular unborn baby, and through the process of pregnancy and at childbirth as well? So looking at the quality of life and mental health domains as well. And then Samrakshan aims to evolve into research into the education practices around fetal radiology, as well as practice strategies, the practice of fetal radiology in the ground, the actual practice, the pragmatic practice of fetal radiology in the ground. So these were areas, niche areas that Samrakshan envisaged as part of its research mandate. From the first to third trimester, looking through a trimester-wide approach to pregnancy, Samrakshan had the possibility and looks at normative growth, identification of high-risk pregnancy, assessment of risk and the effectiveness of risk assessment strategies, risk factors for abnormal outcomes, adverse perinatal outcomes, therapeutic interventions, and effectiveness. It also looks at specific conditions, starting from what is normal for our population, and then looking at preeclampsia, fetal growth restriction, preterm births and stillbirths, and the fetal environment and fetal structure. It's also aligning all of this information with childbirth outcomes. So fetal radiology and imaging studies, normality and abnormality aligned with childbirth outcomes. So the alignment is with childbirth outcomes, and we see it as this abnormality in the fetus actually translate to an abnormal outcome during childbirth. Or does it sort of allow a normal childbirth process to happen? Is it fatal? Is it severe? Is it mild? Is it something that has to be addressed? Is it something that can be left alone? So these are factors that we are looking at in terms of outcomes. And we are keen and we are using a data-driven approach, an approach that is focused on evidence, based on supportive data collected and analyzed from our population, so it's relevant to our population, and comparing it with baseline. We are not looking anymore to base our presumptions, assumptions, or knowledge on speculative opinions that are based on individual experiences. We want data, and we want the data to be replicable. We want to study if it's replicable. We want to study if it translates, if it's done in different places. We want to examine the data and then using a data-driven approach. How has Samrakshan used the data till date that it has collected? It started in 2019 July. It's July 2021, so we have 2 years of data. And how has it used it? We have looked at the effectiveness of the first trimester risk assessment and therapeutic recommendations associated in the first trimester. Essentially, low dose aspirin, 150 milligram once daily at bedtime for women considered high risk for the development of preterm preeclampsia and fetal growth restriction. And we used an adapted cutoff of 1 in 150 for the risk identification. We have looked at the third trimester distribution of fetal growth. We have looked at trimester-specific distribution of fetal doppler parameters and growth parameters. We have looked at the association of various parameters, especially fetal doppler parameters, with adverse perinatal outcomes. And we have looked at the change in the magnitude of preeclampsia, fetal growth restriction, and perinatal mortality in these 2 years. We have used this data to inform health education and disseminated that through different media in regional languages, not just in English, in Hindi and other regional languages, Tamil, Telugu, Malayalam, Odia, Marathi, different regional languages. And we have also used this data for a process of peer education, where we are also using our data forms as learning teaching points. So it's not just a form to just collect data and submit the data. It's also, the data form is also a learning as well as teaching point, informing and inculcating a systematic practice and looking at that to see if there's a measurement error or a systematic bias that is coming and if something is not plausible and has to be looked at. So there's a dialogue also that happens through the data form submission. And that happens to different groups that are being created in WhatsApp for the particular purpose of initiating a discussion and dialogue along the clinical practice, and the data form is reflecting the clinical practice and is then used for research purposes as well. What are the results that we have seen till now? Well, we have seen that the mothers who develop preeclampsia during the course of pregnancy has a drastic reduction, significantly drastic reduction, 4.74% in June 2021 as compared to 9.85% in March 2020. So that's almost a 50% reduction. We also found that only 2.56% of women, that's less than 3% of women who were identified as low risk, develop preterm preeclampsia during the course of pregnancy. So a small number of women who were identified as low risk, only a small percentage of those women actually develop preterm preeclampsia. So the pickup is working well. We also found that only 1/3 of those identified as high risk develop preterm preeclampsia, which translates into the effectiveness of our earlier pickup and early initiation of low dose aspirin between 11 to 13 weeks of gestation weeks of pregnancy. Low dose aspirin, 150 milligram once daily at bedtime. So you're seeing the effectiveness of the first trimester screening protocol. You're seeing the effectiveness of the early intervention using an appropriate dose of low dose aspirin. We are seeing that of those women who were categorized as high risk, only 1/3 actually develop preterm. And considering that there are 3 million women with pregnancy-induced hypertension in India, and if we are able to bring about a 67% reduction there in the preeclampsia rates, it's a huge reduction. We can see how this has reduced and impacted on preterm preeclampsia, 4.74% in June 2021 as compared to 9.85% in March 2020. In terms of preterm births and fetal growth restriction, we are seeing that preterm births have reduced 20.11% in June 2021 compared to 29.54% in March 2020. So in March 2020, almost 1/3 of all childbirths were preterm. In June 2021, it's reduced to 1 in 5. So significant drop in preterm births. And we can see now where that's coming from. We're seeing that stage 1 fetal growth restriction has dropped to 11.76% in June 2021 as compared to 27.27% in March 2020. Stage 1 FGR that was carried to term has improved to 74%, nearly 3/4 are carried to term in June 2021 as compared to 56.94% in March 2020. So you can see the big shift in stage 1 fetal growth restrictions being carried to term. You can see the big drop in stage 1 fetal growth restrictions, which is the most common category of fetal growth restriction. And we can also see how small for gestational age babies categorization has increased 11.28% in June 2021 compared to 4.92% in March 2020. And this shift is a categorization shift, category shift from stage 1 FGR to small for gestational age baby, and is based on the fetal doppler studies. A fetus with an estimated fetal birth weight between the 3rd and 10th centile with an abnormal Doppler study gets categorized as stage 1 FGR. With a normal Doppler study gets categorized as SGA, a small for gestational age baby. So you can see the shift that comes in a category shift with Doppler from stage 1 FGR to or fetal growth restriction to small for gestational age babies. In terms of mortality rates, we have seen Samrakshan has brought about a big change. We don't have the baseline maternal mortality ratio other than what is available for India. What's available for India now is 131 per 100,000 live births in 2021. What Samrakshan is seeing in the areas where Samrakshan is being practiced is 60.64 per 100,000 live births. In terms of neonatal mortality rate, 10.91 per 100,000 live births in June 2021, which is very close to the target that was set as part of the Sustainable Development Goals, compared to 15.32 in March 2020. And when we started Samrakshan, it was around 26. So we are seeing a big drop there. We are seeing perinatal mortality rate dropping down 21.01 per 100,000 childbirths in June 2021 compared to 26.52 in March 2020. And this drop is driven by the reduction in neonatal mortality rate, as well as by a small reduction in the number of stillbirths. Now, much of this data comes from the northern belt, Uttar Pradesh, Madhya Pradesh, Rajasthan, Jharkhand, and we have data from Maharashtra, we have data from Kerala, Tamil Nadu, and several other states. But you can see that if you discount Kerala and Tamil Nadu, which have contributed a small proportion of this data, the larger proportion of data coming from the northern belt, where the perinatal mortality rates are very high. And we can see the big drop in the places where Samrakshan is being practiced. We put out several papers based on this data. This concept paper in the IRIA, we have papers in the Journal of Fetal Radiology that have looked at the screen positivity rates to identify pregnant women in the first trimester. We have looked at baseline information on childbirth outcomes, second trimester screening outcomes, color Doppler studies to identify more fetuses at risk for compromise in the third trimester, routine third trimester color Doppler ultrasound in fetuses with an estimated fetal weight between the 10th to 50th percentiles. Now, this is an important finding that we noticed, that we found abnormal Doppler studies even in fetuses that are routine, that are considered normal, fetuses with an estimated fetal weight between the 10th to 50th centile, that are not considered for closer surveillance because they're considered as an appropriate for gestational age baby, and so they don't need closer surveillance. Everything else is normal, but there is an abnormal fetal Doppler study there that can possibly translate into an adverse perinatal outcome. And that's something that we are looking at. How does that play out in terms of perinatal outcomes? Is it something that we need to consider? Is it something that can be left alone? Can it be a standalone finding without an adverse outcome? So those are things that Samrakshan is now looking at, but it's based on this finding that came from the Samrakshan data. Samrakshan shows a significant reduction in neonatal and perinatal mortality rate at 1 year after baseline. And it's a very significant reduction. Moving ahead, we have to acknowledge that all these results are the result of individual radiologists from different places in India, from different settings. Individual practicing radiologists, radiologists in group practice, radiologists in the private sector, in the public sector, but who all share their data for a common purpose and involve themselves as a team for the development of the data forms, for the collection of data, for the evaluation of data, for the writing up of and dissemination of the results. The team shows us that India-specific problems can be solved by India-specific teams using India-specific data if we collate India-specific data, regional hubs that collate data, state-wise, region-wise, and then we collate all of that into a national data. That is possible. That's what Samrakshan is showing, that that is possible. We have the capabilities for that. Moving forward, we are looking to develop a standardized national fetal radiology data portal, and we are looking to capture data from the machine so that we don't have the hassle of multiple entries, entry into the machine, entry from the machine onto paper, into another form. So reducing all the data capture from the machines and using preset automated analytic pathways to create customized individual, state, regional, national level reports, and in a data secure environment, protecting the anonymity and privacy of the radiologist who is participating, as well as that of the patient who is consenting to give their information for this purpose. And then to grow into developing regional fetal radiology research hubs in India. Now, one thing that Samrakshan shows us very clearly is that fetal radiologists in India have the capability and the skill to collect, collate, analyze, evaluate, and utilize appropriately data that is collected from the population of India to improve optimally outcomes for the population in India. So I think it's high time that we must move on from the regurgitation of Caucasian data to inform our practices. I'm not saying those data are useless. I'm not saying those data have to be disrespected. But rather than just regurgitating those data and those processes, I think we are in a state, we are in a position where we can and we must develop our own data and our own processes and policies that are relevant to our population. We must remember that the population parameters, characteristics, environmental characteristics are different from the Caucasian world as well as from our areas. And hence the priorities of care and what is possible will be different. The resources are different. It's easy to do a molecular test, a biochemical marker test there. There are more labs that are capable of doing it. We don't have that many labs. We don't have that many resources for doing that. So we cannot really think of that as a viable option. They have to focus on congenital malformations because they have already controlled preeclampsia and fetal growth restriction to a manageable level. We haven't. So for us to then focus on the 6 lakhs congenital malformation, ignoring or not considering the 10 to 14 million fetal growth restriction, as well as the 3 million pregnant women with preeclampsia each year, is a strange proposition. We must rearrange our priorities. We must rearrange our focus. We must rearrange our approach. And Samrakshan shows us that a team approach is possible in India for this purpose and can come up with good data that can inform good practices and lead to good outcomes. So I believe we have enough capability within ourselves and that local solutions are possible by every radiologist in India. And I'm emphasizing again, Samrakshan shows that potential and possibility. The take-home question is, do you believe in that? Do you believe in yourself as a fetal radiologist, as a radiologist? And to emphasize that belief, Samrakshan is open and wants and calls for every radiologist who does fetal imaging to be part of its fetal research, fetal radiology research as part of Samrakshan's research process, whether it's a postgraduate resident who wants to do a dissertation, whether it's a faculty who wants to do a study, whether it's an individual practitioner who has collected data but does not know what to do with it or does not know how to go about converting that into a research communication. Samrakshan is willing and wants to and is providing a platform, an umbrella for all of us to get together and look at this data and then apply all of that for the betterment of fetuses in India. Thank you so much. And if every radiologist in India works together, we might be able to bring more color, brighter colors, a more colorful environment, more optimal health, more optimal well-being for the fetuses in India. Thank you so much.